Hello and good evening. My name is Dr. Erica Phillips, and I'm an associate professor of clinical medicine at New York Presbyterian Weill Cornell Medicine. And I'm also the associate director of community outreach and engagement for the Meyer Cancer Center here at Weill Cornell. And I also have the distinct pleasure of being one of the planning committee members for this year's series, week-long series on breast health disparities in the era of COVID-19. I'd first like to thank you for joining us this evening, as we hope to bring you a week of dynamic series of discussions on the state-of-the-art screening and detection of breast cancer and its multitude of options as it relates to treatment. We'll be joined this week by many various dynamic providers between our institutions here at Weill Cornell Medicine and MD Anderson at Cooper. I'd like to let you know that I have no conflicts to disclose this evening. And the three learning objectives that I would like to address this evening are as follows: to define the social determinants of health and how they can impact on breast health, to identify how best to understand the needs of the community you serve and ways to engage community members to improve their overall health, in particular as it relates to breast health, and describe how your practice can select and define a plan to begin addressing the social determinants of health. Before we begin, I have one brief CME question I'd like for you to consider. Do social determinants of health have up to how many times the impact on health outcomes as compared to clinical care? The first answer option is A, 2 times the impact on health outcomes, B, 8 times the impact on health outcomes, C, 6 times the impact on health outcomes, or D, 10 times the impact on health outcomes. Over the course of the next 10 to 15 minutes, as I present to you on the social determinants of health, the answer to that question will become more clear. So what exactly are the social determinants of health? Well, social determinants of health are defined as conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems that shape the conditions of our daily life. While various groups have published different infographics and frameworks to display the social determinant of health, in 2003, the World Health Organization suggested a list of 10 determinants, while the CDC and Healthy People 2020 identifies 5 key areas of social determinants. The framework shown here is used most readily by the Henry J. Kaiser Family Foundation, and it displays 6 domains of the social determinants of health. The first being economic stability, and within that being subcategories of employment, income, expenses, debt, medical bills, and support that allow us to be stable in our economic health. The second category is that of neighborhood and physical environment, and as you would imagine, it entails aspects of housing, transportation, safety, parks, playgrounds, and walkability of your neighborhoods. Education is the third category or domain, and it encompasses literacy, but not only in particular as it relates to health. We can not only be very literate as it relates to our general learning, but still have low health literacy. And so the two are two distinct subgroups of education. Language, early childhood education being very important as a predictor of higher education accomplishments, vocational training, and then lastly, higher education. The next category being food, in some of the other frameworks, is often placed under economic stability, but within the Kaiser Family Foundation framework, it stands alone. And so food as it relates to access to healthy options, but also food scarcity and food insecurity as it relates to not having enough food or hunger. The fifth domain, being the community and social context, encompasses aspects of social integration. While not listed here, often many would refer to social cohesion as an aspect of community and social context, support systems available to the individual, their level of involvement in the community or engagement in the community, and discrimination that they may experience on an individual level. And then lastly, the sixth domain that we are all generally more familiar with as it relates to the healthcare system is that of actual insurance coverage, availability of providers, depending on where an individual may live, and the density of their city. We know that there are definitely areas where is a larger population to healthcare provider availability. The provider linguistic and cultural competency, so their ability to connect with those individuals who may be different than themselves, and the quality of care that is received. And again, regardless of the framework that is used, all of these various domains and subgroups thus impact on health outcomes. Health outcomes being measured across many different ways: mortality and morbidity, life expectancy, healthcare dollars or expenditures, health status, and functional limitations. What we also have profoundly seen based on the social determinants of health is that they have a profound impact on life expectancy. And what we can see as it relates to this impact is that these are two maps from work done by the Virginia Commonwealth University and the Robert Wood Johnson Foundation that have looked at differences within various cities and using modes of transportation. On your right, which is New York City, and on your left, or my left, is Trenton, New Jersey. We see, based on subway stops or rail usage, differences that vary anywhere from 8 to 14 years as it relates to where exactly in the city that you reside. And so for New York City currently, being a provider and resident of New York City, the current life expectancy in New York City overall is 81.5 years. And what we clearly see is that there are areas of the city where we have a higher life expectancy, up to 85 years, and therefore other aspects of the city, no more than a few subway stops away, where that difference is almost, where it differs by 9 years. In East Harlem, where the life expectancy of an adult there is 76 years. And similar, as shown here in Trenton, New Jersey, we see gaps of about 10 years just from when you go a few miles away. And so this, the difference in terms of where you live and you reside, in particular your environmental or your neighborhood context, can have a significant impact, excuse me, on your lifespan. As it relates to the social determinants of health and their contribution to breast health in particular, there are well-documented disparities in breast cancer survival based on socioeconomic status, race, education, census tract level poverty, and access to health insurance and preventative care. Poverty is associated with other factors related to late stage at breast cancer diagnosis and poorer survival, such as inadequate health insurance, lack of a primary care physician, and again, poor access to health care. What I previously didn't state was that when we take into account all of the various social determinants that we just reviewed, social determinants of health have a 6-fold impact on health outcomes in comparison to clinical care. So then what can healthcare providers really do to counter all of these overwhelming forces? So to add a little bit of humor to this, in the voice of yoga, we can keep calm and may the force be with you. But in practicality, there are probably 8 steps to addressing the social determinants of health that can be conducted in your own practice. And so in this intimate wisdom, the first and foremost of these steps is to understand and engage your community, to engage key leadership as it relates to whether it be your medical practice, medical group, or institution, if you're an academic medical center, in terms of their commitment to addressing these social determinants of health. Assessing your readiness as well as your practice readiness. What we know from recent data and multitude of surveys of, in particular, primary care providers, the thought of screening for social determinants of health and not having the ability to do anything about them creates a magnitude of unrest and uncertainty about the validity of doing it in the first place. So it's very important to be prepared and to begin to think about how it impacts on the care and health outcomes of our patients. Next is to select and define a plan. And then most importantly is assessing the social determinants at a patient level, bringing it down to a magnitude in which we actually can, as a provider of healthcare, make an individual difference. Next is to be able to link patients to social determinants of health resources, to evaluate and refine your plan, and then to actually celebrate in the success and the difference that it can make. Given that I just recently shared the various domains of the social determinants of health, and within each one of those domains, there are probably at least 5 to 6 different categories. The most important aspect of beginning to really assess this is to first to narrow it, to begin to select a social determinant to focus on, to choose a health outcome to track, and to find the target population, recognizing that this can't be done across all patients all at the same time, and there needs to be small steps taken in terms of gaining comfortability with the practice. So in the beginning to learn about and understand the community in which you're practicing, this is one resource available here in New York City that I have used probably pretty much over the course of my career, and find it to be a very resourceful way of getting a quick snapshot of the various neighborhoods or community districts within New York. The Community Health Profiles, which is published by the New York City Department of Health, comes out approximately every 2 to 3 years, while shown here is 2015. In 2018, the profiles were updated, and they were updated to align with the Take Care New York 20 priority plans. And so it added to the previous profiles, what were added were far more social determinants of health. The social determinants of health that are highlighted in the community health profiles are also extremely important to how community resources are potentially funded or even created as it relates to identifying gaps. And so this is an example of a community health profile of a neighborhood actually serviced by the New York Presbyterian Brooklyn Hospital. And this is Flatbush and Midwood section of Brooklyn, New York. And to your right, what you see is one small snapshot of how the city has taken data about this particular neighborhood and first and foremost compared it to Brooklyn overall, then New York City, and then also applies a contrast to a neighborhood that is on the opposite or has a desperate outcome. In that, if we can see here as it relates to no health insurance, the percentage of adults in Flatbush and the Midwood section of Brooklyn that are uninsured is approximately 24%, which is higher than the rate currently in Brooklyn and New York City overall. And when you compare it to Tottenville and Great Kills, which are sections of Staten Island, we see that there is a threefold higher rate of uninsured individuals living in this section of Brooklyn compared to Staten Island, where it's 8%. Similarly, if you wanted to have a better understanding of individuals who went without needed medical care, even if it were that they were insured, we see that in Flatbush and Midwood, 15% of the population, again, went without needed medical care. This is in comparison to the Upper East Side of Manhattan, where only 5% of individuals went without needed medical care. Again, so a threefold increase in comparison to one of the best ranked neighborhoods within our city, and 3% higher than Brooklyn and 4% higher than New York City overall. And then last but not as relevant to this discussion as it relates to late or no prenatal care is just another comparison in terms of gaining a better understanding of a small aspect of a neighborhood health profile that it can help a provider understand the context in which their patients are living. So that previous example was one which is really one that requires not much of a significant lift, in that this is information and public data that's available to any individual and can be searched very readily from your home computer or your work computer. What does require a greater lift, and I'm going to show an example of work done by the Meyer Cancer Center, which is really engaging the community and gaining a deeper understanding about individual health from their perspective as it relates to social determinants, and in this case, how the social determinants may impact on the early detection and treatment of cancer. The Meyer Cancer Center's catchment is an area that spans 3 counties. In Manhattan, the catchment consists of below 96th Street on the east side and 110th Street on the west side. And it then consists of the entire borough of Brooklyn, also known as Kings County and Queens. It is approximately 270 square miles in its perimeter, and it's home to 6 million individuals. So a substantial number of individuals in terms of how to, as an institution and a cancer center, to better understand the needs of those individuals. Within the context of the Cancer Center, over the last several years, we have identified several priority neighborhoods. Each one of those priority neighborhoods, at least in Manhattan, is surrounding one of our institutions in terms of the New York Presbyterian Hospital network. So located here, Weill Cornell NYP on the Upper East Side, New York Presbyterian Lower Manhattan, in the Lower East Side, New York Presbyterian Queens and Flushing Queens, and New York Presbyterian Brooklyn in Park Slope. The priority neighborhoods listed here are thus encompassing of those neighborhoods surrounding the hospital, but in addition, they are encompassing of neighborhoods that in particular we have identified had disproportionate rates of premature death from cancer, breast cancer being one of those, in comparison to the contiguous neighborhoods around them. And so in order to develop programming, we wanted to have a better understanding of what were the constituents who live within these neighborhoods, the stakeholders, their understanding or beliefs as to potentially some of the reasons why there may be these disproportionately higher rates of cancer mortality before the age of 65. And so in 2019, New York Presbyterian Brooklyn Methodist, in partnership with Cornell Center for Health Equity and the Meyer Cancer Center, hosted a series of community roundtables in 4 of our high priority neighborhoods in Brooklyn. Attendees that were invited to those roundtables, and this is one of the roundtable discussions hosted actually at the Coney Island YMCA, which was one of our high priority neighborhoods, were inclusive of community-based physicians, elected officials, local cancer advocacy organizations such as the American Cancer Society, community-based members, community board members, and various organizations that service communities as it relates to social services organizations in particular, so housing, food, and immigration. Seating was uniquely assigned in advance to ensure that there was cross-sector conversations so that we didn't have individuals from one or any particular stakeholder sitting with members that they knew, because we wanted to ensure that we engaged everyone around this very vital conversation. And so again, using the framework that I previously shown as it related to the 6 domains of social determinants of health, we asked each group in terms of individuals sitting around the table to answer the following question. Looking at these 6 domains, what are the top 3 social determinants or 3 top domains, the top 3 domains that serve as barriers to the early detection and screening of cancer in your community? And so we really wanted individuals to think about the context of the neighborhoods that they lived in and how they believe that these 6 domains and which of these 6 domains were most important to being a barrier to the early detection and treatment of cancer. And what we found was very interesting. And so using a nominal group technique, individuals sitting around the table were able to first have about 45 minutes to have a group think tank process where they discuss the various domains and the subdomains. And then each group had a designated individual to report out their group's findings. And so at each roundtable discussion, we had approximately 5 to 6 groups, and each one of them reporting out their findings from their individual group, which then consisted of another approximately 5 the 6 individuals. And what we found is when we tallied all of the various groups and then the groups across the 4 neighborhoods, that the number one barrier to the early detection and screening of cancers as well as treatment within these neighborhoods was economic stability. And here's a direct quote to give you a sense of what exactly that meant for individuals. And the quote reads, "After you complete a screening test, you may receive a new diagnosis. Then you have to stop working and tap into your savings, which then begins to deplete." And so what we found was a resounding theme as it related to screening, and that often screening for cancers, a perfect example is obtaining a mammogram for breast cancer screening, requires time off from work. But not only does the screening require time off from work, it is the fear of what the results will determine. And so a new cancer diagnosis, especially now in the era of COVID, during a significant economic downturn where many individuals have lost their jobs, for someone who does have the ability to continue working is something that becomes a substantial impact potentially to their livelihood overall. And so this is, again, just one quote, but there were many similar quotes to this. And this, again, was a discussion not just about breast cancer, but about cancer screenings in particular. And so this, again, was a resounding theme as it related to talking about colon cancer and the time off needed to conduct a colonoscopy, and lung cancer and the time off needed to conduct a CT scan for lung cancer screening. The next category or domain was low health literacy as it related in the category in the domain of education. And a quote that helps to describe the findings here and the thought process was that people only seek medical care when it's getting really bad, especially men who don't go to the doctor because they don't have the proper education. What's not shared here is sort of the deeper richness of the conversations that were had during those roundtables as it relates to the need for greater education of communities, but from more trusted sources in a sense of almost peer education being a leading aspect of how to educate others as it relates to the early detection and prevention of cancer. And last but not least, the third category, under the community and social context, the subcategory of stigma and social isolation. And this quote helps to illustrate what the community members wanted to share as it relates to the stigma and in particular isolation that people experience when they finally do have a cancer diagnosis. People do not like to talk about their illness, they hide it. Thus you don't know they were sick until it's too late. And the too late factor what that was being alluded to was the ability for that information to help others, whether it be in the family to understand their potential own risk for cancer, given that a family member just has incurred cancer and potentially has now been found to have it at a late stage, but also what other community members could do as it relates to that in terms of illness sometimes being an impetus and activation for others to act. And so when it is too late, neither one of those factors can occur. So now going back to thinking about the various resources that are available for providers to begin to engage in thinking about and preparing a practice for readiness for screening social determinants of health. Again, most important was recognizing that across these various domains and these many subcategories, the population that you may be serving, as depicted by the work that we did in these neighborhoods, we were able to prioritize and have prioritized the top 3 social determinants that should be factored in when a provider in the context of one of our medical group practices or hospital is dealing with a new cancer patient or a patient who needs to be screened for breast cancer. And so one tool that is readily available and an open public resource as a toolkit that providers can tap into is a protocol for responding to and assessing patients' assets, risk, and experiences, or PREPARE, is a national effort to help health centers and other providers collect and apply data they need to better understand their patients' social determinants of health. Prepare is both a standardized toolkit that has been used across various populations, and so its validity is solid. And again, in this toolkit, which consists of a series of questions, most important is identifying those questions that would be most relevant potentially to the population that you're serving. And as I previously shared, one of the ways to identify what those determinants might be is to truly either use public data that's available to you in terms of looking at the social determinants for your respective communities, or actually conducting your own roundtable discussions or surveys or ways of polling your community members, practice patients about these factors. So for example, small practice might screen for social determinant. In one instance, it might be food insecurity, depending on the neighborhood and the population that you serve, and refer patients to local food banks in order to address this insecurity. So when returning to our original question and the importance and magnitude of why screening for the social determinants of health is important, as I shared within the context of the presentation, the social determinants of health have up to 6 times the impact on health outcomes as compared to clinical care. And thus with that, I'd like to conclude, and I thank you for joining us this evening.